look like we're on, Bradley? Welcome to Doc Talk Live. I'm Dr. Goodman. I'm with Dr. Randy Cron, C-R-O-N. He is a pediatric rheumatologist at UAB. So the way I found Randy is a friend and a viewer in Atlanta is immunocompromised, meaning he has a history of a blood cancer and also has a lung problem called bronchiolitis obliterans and had ARDS, or severe respiratory problems, maybe 4 or 5 years ago when H1N1, which I think is bird flu, when that flu was going around, and he's got maybe 30% lung function left. And so he is sort of the prototypical patient that if he were to get COVID-19, he is at extreme risk of dying. So he has a vested interest in learning everything about COVID-19 and, of course, avoiding it. So, of course, he's social distancing. But my point in telling you all this is, first of all, if folks want to hear different talks, they should contact Doc Talk Live. And he contacted me and he said, hey, I'm very interested in this thing called Cytokine Storm syndrome. And it just so happens that there's somebody in Birmingham that researches this. And I said, all right, I'll reach out. And Randy, I reached out. I found you on the internet. I appreciate you doing this. So with that preamble, I'm interested in your comment to David's email, post, whatever, as well as how this ties into cytokine storm syndrome. Okay?
Sure. So being immunocompromised either from the chemotherapy or the cancer itself certainly puts you at risk of getting infections and not necessarily being able to clear them well. But and I don't know this for David, but maybe there's also a genetic risk factor that he may or may not have that puts him at increased risk for getting these cytokine storms, or where these inflammatory proteins of your immune system go kind of unchecked and out of control, which ultimately can lead to multiple organ failures and death. So, like I said, I don't know for David, but certainly having immunodeficiency, you'd want to be careful about getting an organism like this.
So actually, I'm going to jump ahead because I want to make sure I cover this up front, and then we're going to back up
Sure.
and talk about cytokines and cytokine storm, which is to say, it sounds like in this particular case with COVID, we want to ameliorate or mollify these proteins from causing inflammation throughout the body. And a couple of drugs have sort of come to the forefront. So I want to start with treatment and then back up. And so those drugs would be chloroquine, is that right?
Mm-hmm.
And azathioprine, which is a Z-Pak. And chloroquine is for arthritis.
A version of it, hydroxychloroquine, goes by the name Plaquenil.
Plaquenil.
And a lot of lupus patients in particular, some arthritis patients take it as well. Just some patients with rheumatic diseases, it has some benefit.
And so why are these drugs sort of bantered about, and what are your thoughts on those drugs to start with?
So those drugs, azithromycin and hydroxychloroquine, have been used, the Chinese have tried them as kind of antiviral approaches. So not so much attacking the immune system, although they may have some benefits there, but kind of going after the virus and its ability to replicate. And they're both relatively safe drugs, but there are some risks of some arrhythmias that can develop, particularly in the combination of the two.
So along the lines of Tamiflu, which is to treat influenza, you've got to take Tamiflu very early before the virus loads up. So first of all, does Tamiflu have any effect on COVID? And also with these other drugs, do you think there is importance in getting on those early should you be infected with the virus?
Yeah, so I'm going to couch all of this by saying I'm not a virologist.
Okay,
Fair enough. I study the cytokine storm aspect of this disease, but from what I understand, there isn't anything to date that's proven beneficial. They've tried various repurposing of antiviral medications, including some HIV meds, for example, and the clinical trials to date in COVID patients haven't shown benefit. There's a drug that people have hoped for called remdesivir that was actually developed in collaboration here at the University of Alabama at Birmingham with Dr. Rich Whitley and colleagues, that is in multiple clinical trials, including an arm here at the University of Alabama at Birmingham on the adult side. So those are kind of all antiviral.
So then let me get off the antiviral approach, because that's not really fair to ask you those types of questions. Let's deal with okay, the virus has infected the human, the organism, the body, and the cytokine storm causes this problem of lung disease, this tremendous inflammatory attack. What would be good to address the cytokine storm? Is that fair?
It's a fair question. And first, I think we first have to say, is this truly a cytokine storm? And I think there's a lot of good evidence, both clinically and based on some of the laboratory values that we see in these patients, primarily those reported initially out of China, that there are features of a cytokine storm, which is this overly reactive immune response that doesn't downregulate and just keeps getting worse. But I also will say that for those of us who have just been learning about this as we go, that the cytokine storm that's associated with this coronavirus infection is different probably than most others that we've seen before, even the ones we've seen with bad cases of influenza, for example. And the reason we think it's somewhat different is that the lung is not necessarily always a primary target organ in cytokine storm, but it clearly is in this disease, and it may be related to the virus, its predilection to attack the lower parts of our airways. But there may be other factors as well, and some of the blood tests we see are not as extreme. For example, a blood test called the serum ferritin can be very, very high in cytokine storm syndromes, and here it's high. Don't get me wrong, it's definitely abnormal, but it's not to the degree that we see in other cytokine storms. And it seems to be less of a damaging effect on the liver. The liver is definitely involved in the cytokine storm, but probably less so than some of the other types of cytokine storms we've seen.
Okay. So I'm going to come back to treatment. I'm going to start thinking about cytokines for a second. This is my understanding of cytokines. I'm an orthopedist, okay? I'm not an internist, I'm not a rheumatologist. But when I think of cytokines, and please correct me if I'm wrong, but I think of these things as proteins, little pieces of proteins that get released during an injury situation. So if I cut myself, I bleed, and I get platelets that start aggregating this clot and stopping the bleeding, but also these platelets release these little proteins, these little cytokines, which cause an inflammatory response, but you need that inflammatory response to actually start healing. That's why you have these cytokines. These little protein molecules are sort of talking to everything and promoting healing, right? So that's what I understand about cytokines. Can you expand on that?
Yeah, sure. I think that there are multiple purposes of cytokines, and there's a whole slew of them out there. And there are some that cause a lot of inflammation. There's some actually there in the immune system to kind of dampen it back down. They're primarily there as kind of hormones of the immune system. So for white blood cells to talk to each other, as well as other cells in the body, but primarily between themselves. And they're there mostly to help the immune system either recruit other cells or do their activities that they're supposed to do to primarily clear infection. They're also involved in wound healing, but infection is really one of their primary purposes, as well as kind of the immune system surveillance for cancer, for example. But they are these proteins that are signals between immune cells primarily that get ramped up during infections. And in most immune responses, let's say you get the flu, for example, you mount a response, it goes up, and then as you clear the organism or the bug, your immune system is also hardwired to shut itself down. Otherwise, we'd be in a chronic state of inflammation, and we don't want that. But what's thought to occur in a cytokine storm is you get this trigger, and then a subset of patients or subset of individuals in the general population, and we don't know exactly why, we think we have some genetic predisposition to do this, instead of clearing and ramping down, they just keep going up. And that's where they get into trouble.
So people that say they've got chronic inflammation, or what are typical just sort of garden variety problems that people have prior to this coronavirus?
So the people who are at probably at apparent risk for getting this in terms of having chronic inflammation, and I'm not saying this is specific to COVID, but certainly to cytokine storms in general that can be triggered by other viruses, for example, are patients who do have some kind of chronic long-standing inflammation. And these are patients, for example, with systemic lupus erythematosus or lupus, and some less common types of arthritis like Still disease, where these are both children and adults who have not only arthritis, but a lot of inflammation that leads to fevers and rash, for example.
Okay, so you have some diagrams here. Is this a good time to look at those, or?
Sure. I mean, these are, the top one here talks about the fact that why is it that 80% of patients who get this coronavirus infection do relatively well? They're either completely asymptomatic or they have a miserable flu, but they don't need to be hospitalized. But another 20% of our general population, for whatever reason, when they get this infection, do very poorly. Now, there are going to be factors in there like age and heart disease and diabetes, and we probably can't address that. But there may be genetic factors that put them at risk for this cytokine storm syndrome occurring. And so we know there's a familial or genetic form of this disease. It's a mouthful. It's called hemophagocytic lymphohistiocytosis, or HLH for short. And we know that in those individuals, there's a very strong genetic component, such that they have mutations on both chromosomes for particular proteins that are important in the immune response. But you can imagine that maybe you only have one mutation, and you're probably perfectly fine until you get the wrong organism or the wrong infection. So maybe you don't have any mutations at all, and there are certain organisms like the Epstein-Barr virus, which are very common triggers of cytokine storm, or COVID is probably somewhere on here. And so your mixture of your genetic background and the degree of insult from your environment, some balance of that puts you at risk of developing the cytokine storm. It's a model.
Okay. And then what's the other diagram you have?
So the other diagram, this is more an immune cell here. And these are a type of white blood cell called a lymphocyte. And we have different types of them, but there are two of them in particular. One called a natural killer cell, or an NK cell for short, and one called a cytotoxic, in other words, kills other cells, CD8, because that's a marker on that cell, T lymphocyte. And one of their jobs is to recognize infected cells and to kill them off, to help get rid of the viral burden, for example. And what we know from the children who have the genetic form of the disease, these kids over here, is that they have a defect in this pathway that kills this cell. And it could be anywhere in this pathway, so there are multiple different genes. But unless you're mutated on both copies of that individual gene, you're probably fine. With the exception that we're starting to see, and we've looked at this in influenza, for example, that you could have one bad copy and be mostly fine until you get the wrong insult or the wrong infection.
The wrong environmental trigger.
Exactly.
Gotcha.
So it's kind of a threshold model of disease where your immune system can balance itself out for the most part, even if you're not able to kill as well because you have a partial or one copy mutation. And maybe you even have lupus or Still disease and you're kind of hanging here, but you're still fine. But then you get that third event, that trigger, that pushes you over the top. But for certain organisms, like this particular COVID-19 outbreak, it may, you may have a mild defect here, and it pushes you over the top pretty quickly.
So getting back to David, we know nothing about his genetics, right? So he could potentially get COVID and be asymptomatic because he's got good genetics for this cytokine, right?
Right.
However, he is at risk if he were to get COVID relative to, let's say, somebody who is in much better health. So what can be done, if anything, to address the cytokine issue
Yeah, so
in general?
Yeah, so for other cytokine storm syndromes, there are a variety of therapies out there that have been tried. Very few in clinical trials, but a couple. And the first drug that we often reach to are corticosteroids. These are anti-inflammatory steroids, not the bodybuilding steroids, but the ones that we use for asthma, for example, that treat severe inflammation.
Now, would these be glucocorticoids?
Correct, glucocorticoids.
Now, I was under the understanding, because I do injections of glucocorticoids all the time, I was under the understanding, and I've been cutting back on the amount we use, because I was under the impression that those could be bad relative to
Right.
this virus.
So everything in life, particularly medicine, you have this balancing the risks and benefits.
Right.
And if you're severely ill in an intensive care unit somewhere and you're dying from a cytokine storm,
You
and
need
steroid,
glucocorticoids.
well, if they work, sure.
Yeah.
And we don't know for COVID-19, but we know for other cytokine storms that they're often beneficial. But we always weigh that against the risk of getting other infections, for example, is pretty high, particularly in the hospital setting where you have tubes and lines going in and out of you. But if it saves your life, and if we can get you off of them in a relatively short period of time, then they're valuable.
So you wouldn't recommend, though, taking prednisone prophylactically?
Not at all. In fact, at this point, no one is recommending corticosteroids for this particular outbreak, because other outbreaks in the past that are similar, other coronaviruses like SARS and MERS, and even other outbreaks of bad influenza, there's very mixed data as to whether steroids help or not. It may be a timing thing, and there's also some concern that they may make things worse. And so, for now at least, we're not jumping to that first.
Okay.
But what we do have are newer medicines that are biologic or designer medicines that we make within other organisms that target individual cytokines or a couple of cytokines. And those are the risk-benefit ratio can be very high because they're not going after cells in your body. They're going after these cytokines or floating proteins that are circulating through your body.
Right.
And they're very targeted to whatever particular one the drug is going after.
So name a cytokine and name a drug. Just
So
curious.
interleukin 6 is one that you'll probably hear about because it's relatively easily measured. It may be an important cytokine in this storm. It probably is. And there are drugs that are antibodies that are specific for the receptor for that protein. So the interleukin 6 or IL-6 receptor that has been found to work in actually other types of cytokine storms, particularly one for CAR T-cell therapy. This is kind of a novel therapy for refractory cancer.
Mm-hmm.
And that therapy, while it helps the cancer, can also trigger a cytokine storm. And there, if they do develop a cytokine storm, these antibodies against the IL-6 receptor have shown benefit. So interleukin 6 is one you'll hear about. It's one that's being trialed in China and Italy and the United States. So there's a lot of places now that are looking specifically at that cytokine as a target. Another target is interleukin 1 or IL-1. And there are a variety of different drugs that can treat that, but the one that's been most commonly used in a variety of cytokine storms is actually a protein that your own body makes. It's just a recombinant version of that. It's an interleukin 1 receptor antagonist, which basically pulls IL-1 out of the system for signaling. And we've used it, and others have used it quite a bit for other types of cytokine storms. And it's got a really nice benefit to side effect ratio because there are very few associated side effects. It's got a very short half-life, so even if it was dangerous, it's gone before you know it. There's a lot of reasons to like that particular agent.
So these are experimental drugs. These are biologics.
They're biologics
made by drug companies that are really in trials. In other words,
for this disease, they are, and we actually have an ongoing trial here at UAB before COVID came out to study anakinra, for example, this IL-1 receptor antagonist for other types of cytokine storm syndromes.
Okay. Anything other? Could he take vitamin C? I hear that, you know, people touting about vitamin C. Or are there any other things that?
Yeah, and this is just coming from my own reading of the literature. Vitamin C, the good thing about it, if you take mega doses of it, you're just going to eliminate it in your urine because it's water soluble. So if it, you know, it's not going to harm you likely. My guess is it's not going to provide a lot of benefit. Vitamin D, you have to be a little bit careful if you take too much of that because it's fat soluble. But in general, it's safe. But this is a bad disease, and I would be shocked and amazed if vitamins could fix it.
Bradley, are there any questions on there popping up? Can you tell anything? We're good there. Still going though? All right. So I'm curious, how does somebody become a cytokine storm expert, or you know, this seems like such an esoteric topic to me, but now it's like, you know, it's front and center.
So for me, I have a lab, so I do basic research and translational research, but I was studying something very, very different when I was at the University of Pennsylvania. And one of my colleagues there, Ed Behrens, who was the co-editor of the Cytokine Storm textbook that came out last fall, we were treating a patient in the pediatric intensive care unit at the Children's Hospital in Philadelphia. And this patient had a cytokine storm. And she was about as sick as anyone I've ever seen. All her organs were failing, and we were desperate. And we used this drug, anakinra, this IL-1 receptor antagonist, talked to the patients, talked to their docs, said, look, what do we have to lose? And she did remarkably well. It was miraculous.
It turned it around.
It just turned it around. And so that just completely flipped my switch. And I've over the years, I've just been transitioning my lab work and my clinical research into this field.
You know, I've heard something about mesenchymal stem cells. Do they have a role in any of this?
Yeah, I'm not sure yet. I think that's pretty premature. They may. Mesenchymal stem cells have been floated out there for a whole slew of disorders, and they may have a place somewhere. But the good news is we have good medicines for this. We just don't know for this particular virus what's going to be the best. And the other good news is there's clinical trials ongoing. So I'm hoping that we'll learn something good, bad, or indifferent about any or all of these drugs within the next month or two.
So from your point of view, as horrible as this situation is, it has sort of accelerated the learning curve as far as cytokine storm and the various treatments for it that affect these interleukins. Is that right?
Sure. I think, yeah, anytime you have something like this, we're going to learn a lot. At the expense, unfortunately, of patients, but this cytokine storm, like I said earlier, is somewhat unique. So whether it will translate to other cytokine storms, I don't know. But the other thing is, I think it's important. One good thing from this outbreak is that it's bringing cytokine storm to the front.
Yes.
And this is that we only are recognizing, I think, the very tip of the iceberg here.
Sure.
And this occurs all over the world in intensive care units, both in pediatric and adult hospitals, with patients with a variety of disorders.
Is there a question there, Bradley?
Yeah. So it says, would you give anakinra to an 85-year-old COVID-positive patient?
Yeah, so there's a lot of ifs in there, right? So are they already on the ventilator, right, for example? Because the other thing that's important about treating this is that the earlier you treat a cytokine storm, the better you're going to do. So the clinical trial that we have submitted, that's not funded yet, but we have submitted to look at anakinra specifically for COVID-19, we want the patient, the instant they get into the hospital, once we diagnose the cytokine storm, to start the therapy. Because by the time they get to the point that their lungs are so destroyed by the virus and the immune response to the virus, it's going to likely be very late. That's not to say it won't help,
Gotcha.
but it's less likely to help than
So
if
once
treat
you
them early
destroy
on.
the lung tissue, it's destroyed.
It's
And
destroyed.
so you got to get it before it destroys. I had a thought and I lost it. Is there any more questions on that?
There's another one. This is more of a comment and then turns into a question. It says, I have mast cell activation syndrome. So many immune system overreacts to anything and everything, it seems like. If someone has MCAS, gets COVID-19, are they at a higher risk for a cytokine storm?
So I don't think we have an answer to any of that. I would just say that the smart thing, like the obvious, is as best you can, stay home, right? Stay away from people till this kind of calms itself down. But there is some encouraging data that did come out of China recently that people in general, and this is very broad scope, who have immune deficiencies don't necessarily appear to be suffering any more than anyone else.
So again, it gets back to the genetics.
That would be my guess, yes.
And so I want to back up. So what is ferritin your biomarker for your cytokine storm? What is your biomarker to say, hey, we're COVID positive and we got a high ferritin? Is it a high CRP? What are your biomarkers to determine, is it anti-Kenra? Anti-Kenra therapy.
Yeah, and so diagnosing this, ferritin is a simple, relatively fast, cheap, readily available screen. It doesn't prove you have it, but it makes you start thinking, what are the other tests I want to order? And at least from our colleagues in Europe, they're saying that some of the liver enzymes, as well as a protein lactate dehydrogenase, which can be very elevated, signs that you're not coagulating well, or coagulopathy, such as a D-dimer, it's kind of a fibrinogen product, a fibrin product, that those go up too. And your platelets, the ones that are trying to stop the bleeding, they tend to come down. And so in the setting of someone who has COVID-19, sick enough to be in the hospital, has a high ferritin and some of these other markers, I think that would probably be enough to make me concerned that they need to be treated. Now, what that right treatment is, nobody knows at this point, and that's why there's clinical trials ongoing.
Sure. And my second question was getting back to the genetics. You identified these genes. Do we test for that at all? I remember doing a Doc Talk Live on genetic testing in Alabama. They have like a free ongoing thing where people give their blood and they sort of map out various diseases in the state of Alabama for people that live here. And I don't know if that was one of them or not, but are there ways of looking at your genetics to see if you're at risk for cytokine storm syndrome?
So whole genome screening, like what you're talking about that's being done in Alabama and elsewhere, they look at all your genes. So the data's there. And even if you identify a mutation, it doesn't prove it's causal. So in our lab, we will take what we think may be a causal mutation, take it back into a white blood cell in the lab and study it and say, does this make sense, does this not make sense? So even if you have a mutation, it doesn't prove that it puts you at risk. But if the rate of these mutations is higher than you'd expect in the general population, it also makes you think that's what's going on.
Okay. Any more questions there, Bradley? So I guess final question. So what is it that you're doing in your lab? I'm just curious what your lab is like.
So we take patients who have mutations in these pathways that lead to the familial form or the genetic form that presents in infancy. And if a patient, an older patient, anyone essentially outside the age of infancy, has a cytokine storm, and we screen by genetics for these mutations, or we're actually looking for novel mutations in different genes that haven't been identified as being associated with this, then we take those mutations and introduce them into these killing cells, the natural killer cells, and see if it affects their ability to kill.
Interesting.
Kind of
so this is done in vitro?
In vitro, correct.
Gotcha. Okay. So, Randy, this has been, I'm tired. It's just, this has been a lot of information. I hope, some of our viewers obviously are quite well-versed, probably even more well-versed than me. So I'm sure there'll be some questions that come through later. I want to thank you so much for taking the time to do this.
Sure. Well, thanks
Appreciate
for
it.
getting it out there.